years.
Oh,
I'm going for Guinness Book of World Records.
okay.
Of interim?
Of interim. All right, then, never mind. She is going to discuss childhood overweight and its effects on the cardiovascular health.
Okay. So we'll first let you see the regular Envision webinar announcements. Tell me how long.
Oh, you could just
Okay.
go through.
So, and then the disclosures here. I have no disclosures myself to give you, so we'll go right into the objectives. So today what I'd like to do is just talk about some of the cardiovascular consequences of being overweight during childhood. I'm going to get a little bit into exercise, and I heard Kirsten already talked about exercise, but I'm going to talk about some of the terminology to help you look at the literature. And then very simple exercise recommendations, a little bit of diet, but not as much as the nutritions. And then finally, we'll have a couple of comments about drug treatment. So I'm sure you've seen these many times, and the exact numbers vary depending on the data, but we know that at least 30% of children are overweight now, and that overweight children have a high risk of staying overweight for the rest of their lives. For us adults, it's worse. Maybe 7 out of 10 adults are overweight, and we're concerned about risks of diabetes, metabolic syndrome, gout, colon cancer, arthritis, loss of mobility, and just daily living. So we've all heard that, but I think when it gets confusing is when is it just overweight, and when is it healthy, when is it not healthy? And so it's important to know that overweight doesn't actually equal metabolic syndrome, and we'll look at that. So just some statistics, about 30% of overweight adults are metabolically normal. And actually in some Asian populations who are very thin, they still have metabolic syndrome. And then somewhere, you can see this varies on the literature, but somewhere between 5 and 45% of normal weight adults will have abnormalities that we usually think of being associated with obesity as far as their lipids and that kind of stuff. So the point I want to make is that we've had a lot of talks about how do you bring up weight without hurting people's feelings, but basically these recommendations are for the health of all children, and I think we shouldn't think of it as being about weight. It's just what we all need to do to be healthy. So let's talk a little bit about the terminology. BMI is one thing that we use, which is body mass index. So it's just the height in kilograms divided by, the weight in kilograms divided by the height squared. So there's just looking at that equation, tall people are lucky because they get 2 full or 2 to the squared, right? But if you think about this, it's looking at the whole body, so it includes subcutaneous fat and what we call visceral fat. And a lot of the literature in cardiology is that actually what puts you at risk is not so much what's on your limbs, but maybe what's hanging around your viscera. So there's a lot of information about waist circumference instead, as maybe that's a better way to measure it. My husband says that he and all the middle-aged guys go to the gym and they try to keep their chest bigger than their belly. So I thought that's a good way to...
Yeah.
So, but actually it's interesting because I just this week saw, one of the pop-up articles in cardiology was now back to, well, maybe BMI is better than waist circumference. So I think the answer is that we don't have a perfect measure, and it's more complicated than just one measurement.
Quick question, Dr. Goens, if I may. So are you saying that the waist circumference is really what correlates with the degree of visceral fat?
Yes.
It makes sense, girth.
Yeah, and they've always talked about, even years ago, about what sort of body shape had higher risk for diabetes, for example.
Yeah.
And that is kind of saying the same thing about, it does seem like what we carry in our viscera is what puts it at risk.
Apparently it's shape.
Yes.
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 It comes down to shape, apparently.
Yes. And so...
But...
Yes.
Sorry, this is Kathleen Colleran. I don't know if anybody saw this, but on the health section in the paper on Monday, there was some contestation of that maybe the pear increase, was it for diabetes or heart disease? Or just
versus the
inflammation?
apple, or-
Yeah.
Yeah.
I saw
Not versus the apple, just the pear in and of itself versus maybe a banana
Well, because I think that the
or a
problem-
string bean.
I think one of the problems too is there's different body habits for men and women. And so, I mean, a lot of us women are more pears, right? So then what did it say about that?
It didn't.
Oh,
I was thinking
I
of that
think
when
the
I saw it.
take-home message was just don't rest on your laurels if you're a pear. You're not safe.
yes. And that's what I'm trying to say.
There you
about-
go.
What I tell my patients is just because they're skinny doesn't mean they're fit. And so I think that's an important message too, because I know
Right.
I'm not that fit. So, no. So metabolic syndrome in adults. So technically there's 4 components to metabolic syndrome. There's abdominal obesity, hypertension, high blood sugar, and then abnormal lipids, which are usually a low HDL, which is the good cholesterol, and high triglycerides. But for children, it's very hard to define. If you try to read about it, it's all over the place because it varies with age. So I think one way to think of it is metabolic syndrome is not truly an entity. It's just a group of abnormalities that tend to lead to type 2 diabetes and atherosclerotic heart disease. So instead of thinking of it as an actual thing, that's more helpful for me. So a couple of things about the prevalence of metabolic syndrome. It increases with the degree of obesity. So if you try to define it in children, we do know that if your BMI is over 33, about 38% will have metabolic syndrome, those 4 things. And if you're severely obese, for a BMI of over 40, and remember we think that normal is under 25 for adults, then 50% of severely obese children will have the abnormalities in high blood pressure, lipids, and that. So, and then we've talked about this here before, but when I was trained, we always thought that fat was just a storage place for energy, but now clearly we know that it's an active organ or active cells, and fat cells produce cytokines. I have to practice that, and those promote inflammation. So it's not uncommon for these kids to especially have asthma, and then once we're adults, cancers, coronary artery disease. And then also, just on the side, the idea that it lowers your vitamin D levels, and there's a lot of literature now that vitamin D is important for our risk for cancer. So this is trying to sum this up a little bit. I'm not sure it makes it perfectly clear, but if I just point, so you have one circle that's all of obesity, and then you have a circle that's insulin resistance or type 2 diabetes, and it's kind of everything coming together in the middle that's actually metabolic syndrome, with its 4 components of abdominal obesity, abnormal lipids, high blood pressure, high glucose. And then sort of the consequence of this overlap is in this circle with the inflammation, vascular abnormalities, cortisol for Catherine. And also what influences this is our genetics and ethnicity, and then this leads to our risk of atherosclerotic cardiovascular disease and type 2 diabetes. So it's just kind of how they overlap to bring a picture. So, and just briefly, we hear the dangers of diabetes, but I think it's important to look through them, because I'm always amazed when I see young parents and their young grandparents who are younger than me are already having these problems. It's pretty scary when you're, it's a little surprising to me that just their family experience doesn't scare them, and I'm sure it does, but whether they're bringing it out. So just to list that, as far as the eye findings, 20% of people with type 2 diabetes at diagnosis already have signs of proliferative retinopathy, and that's a leading cause of blindness. The kidney, we know that 15 to 20% of people with type 2 diabetes will develop chronic kidney disease. They have proteinuria, which eventually is irreversible. And then hypertension in itself accelerates both cerebral and coronary atherosclerosis. We hear about the peripheral neuropathy that makes it difficult to feel toes, and so you have peripheral sores and amputations eventually, and also an autonomic neuropathy. And then, of course, heart is what we think about the most, so all of us eventually will have a myocardial infarction if we live long enough, but it becomes 3 to 5 times more common, and it's the leading cause of death. So that's kind of depressing, but the way I like to think about it when we talk to parents is that we have some things we can change and some things we can't. And so we just need to concentrate on the things we can change. So clearly modifiable things are our exercise or fitness, our weight, not smoking, diet, and then although we can't completely change them, we can definitely impact lipids, glucose, and blood pressure. Non-modifiable, we know, are genetics, gender, and aging, and also for our pediatric audience, for example, Kawasaki disease. If we had some injury to our coronaries ahead of time, I take the chance for all my Kawasaki patients to be able to tell them, you can never smoke and you have to, but there's an excuse, so. All right, so how can we predict the future? Well, it's this balance. Opportunities for energy intake versus opportunities for energy expenditure. And this big question, how are our children's middle age compared to ours? So this study, I think, was very interesting because it is tough. Sometimes when you read this literature, it's pretty short-lived or short periods of time that they're looking at people. But this was nice. This was published in 1992, so a little bit old. But way back in the 1920s to 1935, there was a Harvard growth study. So they looked at the height and weight for 3,000 school-age children. So they were enrolled in second grade, and then they took their height and weight for every year through high school. And then that group of people was recontacted in the late 60s, so they would have been about 55 years old, and they got more information about their height and weight at that time in middle age. And then finally in 1988, they went back to either interview or death certificates, and they divided them into two groups. The group that they considered normal, which their BMI would range from 25th to 50th percentile. And then this is actually a little bit laughable because BMI of 75% is not so bad these days, but they define their overweight group as a BMI of over the 75th percentile. And then the group had to be in one group on at least 2 measurements in their teenage years, between 13 and 18 years old. So the scary thing is that those people who were overweight during adolescence had increased risk for all-cause mortality, cardiovascular problems, and cancer, even if their BMI had normalized in adult life. So it's not good enough to be on The Biggest Loser and get skinny when you're an adult. We have to take care of this in childhood, and probably even before adolescence, if we're going to help our kids when they're our age. So what's the good news? I think there's a lot of good news just in how much, just like that Envision exists, and a lot of people are paying attention to this, and there's salads at McDonald's and stuff like that, right? So simple changes can actually have an impact, and all pediatricians and other child care professionals are starting to realize that we don't necessarily work with individuals but families. And once you get out of bed, exercise and healthy food does make us feel better. I still haven't gotten over the how do you get there. Then I feel better afterwards, right?
That's the 5 o'clock swimming mornings like this morning. I feel really good when I get out of the pool.
Out of the pool, but not when you plunge in. And then, like I said, awareness is increasing, and really, I'm pretty excited. I gave a similar talk to this at Isleta, and the other speakers talking about all the things communities are doing to try to solve the problem really is where I think we're going to have an impact. So, okay, that was the general. Now you have to do equations. So, for cardiology, we talk about the oxygen consumption as a way to measure somebody's fitness. And so, if you think of oxygen consumption, it's just the ability of our body to take in, transport, and use oxygen. So it involves what happens from the lungs, heart, and muscle. And so I like equations. So this equation for VO2 max is cardiac output times oxygen extraction. And if you look at that, cardiac output is just how much blood goes out of your heart, liters per minute. And oxygen extraction is just the difference of the oxygen in your arterial side versus your venous side. And then to think about it even more, if we break down cardiac output into its components, which are just heart rate times stroke volume. So stroke volume is just every single beat, how much is sent out of heart per beat. And so this is the equation. And then if we take that equation and think about what happens during exercise. So here's the equation up here. And I'm just look at what these numbers are at rest and at peak exercise, okay? So, for example, if my resting heart rate is somewhere between 60 and 80, and then we know that at peak exercise it's 200 minus your age, and then usually we think that we don't really hit but 85% of that. But kids can clearly during exercise get their heart rate up to 200, and when we have them in the exercise lab, they often go above 200, and that's normal for them. So if you just do the math, that means just based on heart rate alone, we increase our oxygen consumption 2.5-fold when we exercise at most vigorous. Stroke volume, you'll just have to take my word for it, is your heart can relax and accept about 1.5 to 2 times more with each beat. Oh. And so that's a 2-fold increase. So just with cardiac output, theoretically, can increase 5-fold if you're really exercising vigorously. I don't think most of our kids exercise at that rate, but. And then what about oxygen extraction? Well, if you have healthy lungs, your arterial oxygen saturation should always be 100% because you should be completely filling up your blood. But what happens is you extract more, so your venous saturation actually goes down. So in that case, you can get another 2 times your baseline oxygen consumption. So theoretically, we can actually increase our oxygen consumption by 10-fold. And as we know, the blood vessels relax to accept the high flow, so that's good for circulation. And with improved fitness, we actually become more efficient. So people can sustain a higher VO2 max and sustain it longer. So even though he's in deep trouble, Lance Armstrong is actually amazing. The VO2 max he could sustain for how long was what made him so well, regardless of how he got there, do so well. So that's all fine. That was more to just when you're reading the literature so that some of these equations and names of things make a little bit of sense. But how do we translate that into what we should be telling our kids to do? I'm a little bit surprised sometimes, and maybe this is just in cardiology clinic because people are worried about their hearts, but a lot of my teenagers, they don't want to sweat. They don't think, I ask them what they want to do for exercise, and they never want to be sweaty. So we have to talk about sweaty is good. You want to be sweaty sometimes. So
well, the other thing too, I think is interesting, and when I was coaching youth soccer, I ended up with kids in that situation who are not club soccer players. Now, my kids are in a different situation, but this idea of warm up, when your heart rate starts to go up and you start to become uncomfortable, and letting them know that they're not going to have a heart attack exactly at that point as you're going through that transition. And it's even when people are in shape, you still have to go through that warm-up period. So even walking up the stairs here, your heart rate goes up and you're breathing hard, and and that's not because you're out of shape. It's because you have to make
or your second wind.
You have to make that transition.
Yeah, your cardiovascular system has to catch up with how much exercise you're doing, and the same on the way down. This is kind of off, but a lot of people who faint after exercise is because they're not cooling down,
Okay.
and so it's both the speed up and the cool down that they really need to be doing.
But it's interesting that kids will talk about being uncomfortable in that warm-up period as they notice their heart rate's going up, and
Exactly.
they're like, I'm in trouble, I'm breathing hard,
And they never get over that hump.
Right.
So actually, when we do formal exercise stress protocols, the kids always think, this is nothing, because we start very slow, actually. And then we increase the fitness, we call it the Bruce protocol. So most kids are extremely bored for the first 5 to 8 minutes. And then we really pick it up. But that's important, because if you just pick it up, they're not going to be able to reach their VO2 max. They will give up before. So I think you're right.
That explains why in exercise phys labs, sometimes we would do VO2 max on people and then they would collapse when they got off. They were like really going at it.
I always, actually, in adults, they often stop it suddenly because they're afraid they're...
Right, yeah.
I actually, in kids, we do the recovery, because a lot of detecting their fitness is watching that recovery.
Okay.
And also, actually, on a little side, if you're going to have an abnormal rhythm of your heart, sometimes it happens in recovery, actually.
Oh.
And so we usually slow them down and don't take them unless we have to look at their echo. So,
Okay.
yeah. All right. So
fall off the treadmill and faint.
Yeah, a few of them did.
Yeah,
They were really going at it.
and we always have our nurse back there to catch them, actually, because sometimes. So what about for kids? So, we can talk about exercise for adults. This I grabbed off the CDC website that I liked, because it does talk about aerobic, moderate, and vigorous, and then it gives example of things you could recommend for them to do for children and then adolescents. And it even has some housework in there, so that's nice, because other things are exercise. But then with kids, the CDC, we're thinking about weight and all this stuff, but they also want you to be thinking about muscle strengthening and bone strengthening. And so if you look at like bone strengthening, it's more impact, what we would think about high impact, like running and jumping. And then also muscle strengthening, some of these things that are what we would consider isometric, like tug of war or sit-ups maybe, stuff like that. So for children, they really should be getting a whole variety of exercise. But the bottom line is that getting your heart rate up and really being more vigorous than just walking. So how do you translate that a little bit? Because I think sometimes everybody's different what they like to do. I like my little pedometer, because I feel like I've accomplished. When I forget it, I feel like I haven't exercised all day. But somebody at the exercise gym, she goes, "You count your steps? Why would you do that?" I said, "Because I'm compulsive." And
You're a numbers person.
You got to put it in my equation.
But so, we use this 220 minus the age. If you're only 10, then that's pretty high. And then usually people don't really meet the max. The max is 85% of that. But if you just looked at where are we getting as far as high versus moderate, say I was 10 years old. So moderate would be maybe 140, and high would be pushing 190, 200. So sometimes people like to check their heart rate to kind of see where they are. So this is just meant to give a ballpark of where your heart rate would be if you were doing low, moderate, or high intensity. So, go a little bit fast. So what about the barriers to exercise? Because I think this is mostly what I hear. And we talked about fat cells giving inflammation. So the number one that I hear is a lot of our kids have asthma. Or they think they have asthma from just what Kirsten said, is they start to exercise and they start getting out of breath. Their parents see them being flushed. I get that all the time, but they get flushed and thinking that's an abnormal thing. But it's really going to affect what kind of exercise they can do, because asthmatics actually will get better if they get fit, but getting fit can be tough. So sometimes swimming is good if you're allergic to grass. You could swim. Kirsten can talk about this. I always had problems with swimming because the chlorine would dry your throat, and so I hear that from kids too. But now there's some non-chlorinated pools.
Yeah, salt pools and that kind of thing. And the idea that you've got a vapor layer over the pool, which is why we think it works well for children who have pollen-related kinds of things, because there's actually filtration that happens in that 12 inches or 8 inches above the pool.
What about the germs from everybody else who's breathing on that layer?
That's just good immune system practice.
There you go.
Germ theory, you have to have a little bit of a challenge.
Yeah.
But yeah, there are more and more pools that have salt filtration systems. Now, they still have bromine or chlorine in them, but they're at lower levels than what we used to have, that turn your hair green
And your bathing suit.
and your bathing suit just disintegrates.
So, and then another, of course, if orthopedics concern, especially the knees and in children who are overweight. And so I think as you're talking about what you want to do, addressing those so that they can be successful is good. We already talked about family beliefs or fears about exercise. Some people who are so worried, sometimes I will get an ultrasound of the heart, because something about actually seeing that the heart muscle is good and strong, because everybody thinks heart attack, and they don't really understand the difference between age-related risk for heart attack, especially with the media talking about sports a lot. So, and then we've all talked about, what about the environment? Just thinking about how easy is it to get out? What can you do? Is it fun? So for the American Academy of Pediatrics and the American Heart Association, and then Beth Goens, that's what this has changed. Sometimes they only say 5 days per week, but actually a lot of them say every day per week. I think people, to me, this is kind of made up to sound good, but I think a goal of 60 minutes of moderate exercise every day, knowing that it doesn't have to be an hour all at once. And so I do think just having it every day would be a nice goal, because every once in a while you can have a day where you vegetate, but that doesn't mean you can't do something. And then age appropriate or play, and always more effective if the parents join in. So I think that's the biggest thing. People complain that, well, he doesn't like to go outside. So go outside to the zoo with him. I think kids want to please their parents. So these websites, there's many websites, but I usually use American. It's actually, they've shortened this. Instead of AmericanHeart.org, it's just heart.org, but you can find it on either. And then the American Academy of Pediatrics. They actually both have places that give you hints about, how do you develop a heart healthy home. And these are just a couple of things: family walks after dinner, throwing a ball in the yard, cleaning with everybody involved, make it into a game. And then this is just what I added. I think there's so much criticism of our schools about, do they give our kids enough exercise? And I actually think it should be done at home, and school would be an added benefit, because they're not in school year round. So what are the benefits of fitness? You get a higher VO2 max. You can achieve a higher VO2 max. And so you can do a lot more exercise before you get out of breath. Metabolically, we're going to improve lipids, blood pressure, and insulin resistance. Psychologically, it makes us feel better. And then all the literature, our literature, show that these benefits occur before the weight goes down. So I've actually taken to just saying that out loud to some of my teenagers. You don't have to be I'm not trying to get you to be skinny or thin, or I like you the way you are, and you can do things for your health even without turning into a skinny person, or so how do you, as the care provider, how do you recommend what they do, or what kind of prescription should you give? And so one thing has been MD Fit, which I just think is easy to remember. And what MD is the mode of activity, so trying to tell them what they might try to do because it's not always common sense. And then D is the duration. So I have them start really simply, maybe only 10 minutes, and then increase 10% every 1 to 2 weeks as they're feeling good. But I always get back to our goal is going to be an hour a day of being hot and sweaty, and or at least
nice
getting
and
our heart
cool in
rate
the
up.
Pool.
Yeah, or getting your heart rate up. So, and then
Actually get hot in the pool too if you're actually doing.
Like really vigorous.
Oh yeah. I mean,
Yeah.
your face is red and you're
Yeah.
because the water's cold.
Yeah.
So
yeah, cooling you off.
going up.
And then for kids, at least every day, but then getting back to this thing that changing it up, so 3 days aerobic, 3 days muscle strengthening, 3 days bone strengthening might be one way you could suggest that they change it up. So that's 9 days, but you can do more than one thing in a day. And then I talk to them about intensity more simply as like thinking about your heart rate's going to go up and you're going to feel a little out of breath and you're going to be sweaty, but if you're doing vigorous, just talking about what do we mean by moderate and vigorous. And then getting back with them, which can be tough in our ability to follow up. So here's Envisions. I don't know if you guys have updated this, the last day of this talk, but here's an example of a prescription for health. And just going through with the family and the patient, what do you want to do for exercise? How often are you going to do it? What are your goals? And this has some diet goals too. And then just getting back with them. But I think this is important because we hear people say, why can't they do it? But we do. All of us need some kind of concrete things to try to do. So summary of exercise, I'm going to be 5 more minutes. Is that?
But no, you're fine.
So summary of exercise is that fitness is important for the whole family. And so I really think we're doing the parents a favor and the children a favor so their parents will be around longer for them to bring the whole family in. And get an activity history in everybody so you're not singling out the overweight kids. This is just what we talk about. And same with exercise. Don't rely on the school or organized sports because a lot of my kids, they're in AAU. They're really active and then they sit and play video games for 2 months in the summer.
Yeah, that was sort of our discussion this morning is those times off and then starting back up again.
And also, my concern is that I want to teach them something they can continue into adult life. So that's one of the problems with team sports is we don't get as many opportunities to get a team together to do something. So, and then involve family or, since teenagers might not want to hang out with their parents, talking to them about things their friends might do, even though in my family we call shopping the S word. I don't like shopping. But, if kids want to go to the mall and walk all day at the mall, that's okay. Maybe. What else they can get into. So write a prescription and follow up. So
I have a question. So what about, actually first a comment. We did, I think, last spring look at some data about how kids do gain weight in the summer. And it's almost like cyclic dieting, if you will, which we know is actually a risk factor for heart disease. But so it tends to, they'll lose weight during the school year, gain weight during the summer. They won't lose it back. So they're steadily going up. But it is like cyclic dieting, if you will. So that's one thing to be aware of. My question is, what do you do for the kid who is active and is overweight? So let's say they're involved in a regular activity and they're doing 60 minutes. Do you bump it up? Or do you go to what you're going to talk about next, which is diet?
Well, I think also I do talk to them about doing something outside of the sport because we actually get this a lot, especially in football. Because the football coaches are like, they're thrilled to see a 350-pound lineman who could do that. But I'm not convinced they're that active at practice.
Okay.
So I like to hear what other people say. So I go back to this, like maybe you should be doing something that's not necessarily exercise, but just what are you doing to be active outside of your sport type thing. And then I think it's just a goal. So that's where I would do it. I don't know, you coaches, how other people would say that, but I do get back to, because I only have them about 4 or 5 years, I'm not sure I'm going to make that person thin. And so I feel like if we can teach them some lifestyle things, if they're making any progress, I'm pretty happy.
I think a good way to sell it to them, like I have a football player who's like totally bought into my healthy lifestyle because the way he feels at practice. So they kind of get there and hit, and then they run off huffing and puffing. And I told him, I swear to you, if you start, don't eat at McDonald's every day, but you keep your weight with healthy foods. And he's agreed to add 30 minutes of cardio every day on top of that at the gym, which all these football players have access to, the school gym, and they're there hanging out. They like doing it. He's like, I have so much more stamina and energy than the rest of the guys in my position. He's like, I go there, I feel good, I have energy all day long to study. And he's really bought into it, not the losing weight, because his coach is like, you need to be a big guy and blah, blah. And I tell him, these professional guys, do you think that they eat at McDonald's every day, or do you think that they have like a nutritionist and, people helping them get to the top of their game? And then they're like, okay, well, I'll try it.
But see, I think the kids I struggle with more, because those guys are being exposed to community, like to healthy. It's the children that don't have a role model that I struggle with more, and that's where I think their parents really should kind of try to be the role model. I know it's hard.
Yeah, we talked about that all morning.
Did you?
Being the model. Yeah, and there's a lot of research now in adults that people that work out 1 hour a day and then plop around the rest of the day actually don't have a good benefit. That it's healthier if you're a busybody, you clean your dishes, you wash your clothes, you hang them on the line, you walk your dogs, and you do these kind of things all day long. You have more of a benefit than. And I think it's easy to get in that mindset, like, I jump rope for 20 minutes, now I can watch TV all night, and you feel good about it, but your body might not be benefiting.
Well, that's why I think on the CDC, looking at other activities, and the fact that it's not an hour all at once.
I know, I like that. There's actually a lot of, there's some woman at UNF who studies heat shock proteins, and she went to a conference on exercise, and they study just what standing up does for your health. Just getting up several times a day, all these health benefits.
That's why you guys have the desks.
Yeah, we've changed about most of our desks here are standing desks. I went to a standing desk. It makes a difference.
I did read a study about the accidents and the decrease in productivity from the treadmill desks.
Yeah, no, we don't have one of those, but just the standing desk. And we can sit down when you do need to sit down, and it takes you about, I would say it probably took me 3 weeks to get used to standing, and I'm someone who's in shape, but it's a different body position, and parts of you hurt.
Right.
After, standing, even then when you have everything adjusted the way it's supposed to be adjusted. It takes a little bit of time to get used to, but it's a good thing.
I'll try to dictate standing up, because that's easy.
Up and
just
down's
have the
a good
phone
idea.
and you don't have to. But so what about diet? I don't do the detail that Kirsten and Kirsten do, but what I can get in is very quick tips, and I try to do these couple of things. You guys can say if this is doing any good, but I usually do ask them to quench their thirst with water first, and then if they want something with taste, that's okay. I joke that Gatorade's for Florida Gators. That's Florida in August, full pads for 4 hours. And I don't think anybody in New Mexico drinking Gatorade is doing that. Maybe they are. And then talk about trying to move towards skim milk, because I say, but you guys tell me that whole milk is 3%, right? And
it's
so
like
people think
3.5.
Yeah, people think whole milk is so good, and then you go to 1%. I'm like, really, it's not that much different. So trying to get them to like it, and then with the juices, I actually think if you dilute them, it's a lot cheaper and it's healthier, and the kids don't have a taste for that really thick juice. I have a hard time with how thick some of the juices are. So. And then the big thing is, especially in my Las Cruces clinic, I see a lot more overweight, and this idea that not letting them stop when they're full. So letting them listen to their own hunger, and having healthy snacks available, And then the set a good example, which that's the one I struggle with the most, and not to be sexist, but we only have one man in the room. But usually what I hear is, we try to do it, but Dad wants to have Coke and potato chips for his beer games. So I think it is hard when only one of the parents is
Sounds like all
deciding to do it, or if the adults feel like, I'm an adult, I'll do what I want, right? I'm already grown, I don't have to be healthy, so.
I hear that all the time. So I just tell the moms that's okay as long as you're being the example, your kids are going to remember that. Yeah. So if Dad's disagreeing but you're doing it and you're out being more active than Dad, they're going to see that.
Yeah. And dads, I actually get them in and talk to them because they want their kids to be well. I just don't, I don't think we should assume that it's common sense because, at the Olympics, who was advertising at the Olympics? Coca-Cola and Pepsi-Cola. So,
Our professional conference.
Yeah.
It's bad.
So, and then ask the families what they think they can realistically do because we can throw things at them, but whether they'll do it. Finally, I did want to put up some of the websites to find things. Educational for Parents, this is the heart.org. And I walked through the links to go through them, but I just wanted to give you one example because it's like how to deal with a picky eater. Are there games you can play, cooking with your kids, stuff like that. Here's just one example. They're all on one page. This is Make Fast Food Friendlier. So they have a bunch of these, and so this is going through just telling you if you do go to McDonald's, what should you do? And they have many of those little one-page things that you could share. And then they do have things for community. So on the Heart Association, it's more for educators, these different programs, because I do think kids get excited when they're involved in a program. And you can actually sign up and make money for your community center or your school by doing these American Heart Association things like Hoops for Hearts. This is actually the American Academy of Pediatrics has this HAF or Healthy Active Living for Families that's very similar. Has things. I like this. This is just a 14-page book. You can download the PDF, and it really is focused towards family, physician, and everybody. And it goes through just all of the things we've talked about: diet, exercise, getting together as a family. And so I like this resource just as somebody who wants to learn. I'm not sure it's what you hand out to parents, but understanding childhood obesity. Very brief about medications, because you have us here, but we hardly talk about it. But clearly, lipid-lowering medications, statins, can be effective and safe. Many advocates are pushing to use them in kids as young as 8 years of age who are at high risk. But the idea is not, how should I say this? They're high at risk, but high lipids despite an adequate trial of diet and exercise. So I actually changed this. I used to say despite a failure or after a failed trial, but that's probably wrong because I want you to continue the diet and exercise. And the argument is more that if you haven't done an adequate trial of diet and exercise, you actually haven't done what's the best thing for their lipids. So it's not instead of diet and exercise, it's with an adequate trial of diet and exercise. So LDL of greater than 130 in anybody, but they actually lower that to like 110 if you have family history and other risk factors. But as I've said before, medication compliance is very poor in the long run. Some studies show less than 50% of people are still taking their drug a year later. And so if all you're doing is throwing a statin at them, you're not changing their life. You're just fixing that cholesterol for that period of time that they'll take the drug. And then changing diet, daily exercise habits are more important. Hopefully we can sustain it and we can't substitute. So in summary, definitely our understanding of obesity, metabolic syndrome, and diabetes is evolving. Exercise is the best modifier of all the risks. Diet's hard to change, but we have a lot of community things that are going to help us. And resources for people in the community, Envision, of course, New Mexico AAP, and the Heartorg are good resources for patient and provider education materials.
And BG.
And BG. Oh, no. I really struggle to follow all these things, so I always can have sympathy, right?
So perhaps it's being good.
Yeah, or baby girl or something like that. All right.
Being green.
Question for you. Dr. Goens, would you mind going back to that slide number 30, a couple slides back with the brief word about medications? Yeah, so on that second point, we could think about that as needing to have an adequate trial of diet and exercise first before considering statins.
So there's actually very nice algorithm through the American Academy of Pediatrics where, you know, I get a lot of consults where they'll say their total cholesterol is 240, their LDL is 110, what am I supposed to do? But you make a change and then you recheck it in 6 months, because we have to remember that we're trying to affect what their middle age is going to be like. So we have some time to do this. A total cholesterol of 240 is not an emergency on that day. You know,
right.
So basically, if you go through the algorithm, the American Heart or American Academy of Pediatrics, it's really, you find they have abnormal lipids, unless they're very high or there's a familial sudden death.
Good point. Go
then
ahead.
6 months later, you recheck, how have we done? 6 months later. So it's not really until you've already been taking care of them for a year or two before you're starting to think about statins, unless they have such a high cholesterol and very early coronary artery death and stuff like that.
And I was really thinking in my question when asking this about the overall approach. And would it be accurate to say, yes, we do use statins in youth after an adequate trial of diet and exercise?
It depends on what their cholesterols are.
Okay,
So
gotcha.
basically, I choose it. I think before these new recommendations came out, we all thought you didn't until they were 13. And so what that point is recently pushed much by the head of pediatrics in Denver, he's like on all the committees, is this idea, could we treat younger? And so that's the newest idea. I don't know if that makes sense, but I really don't think that, statins should be added just because you have somebody who will not exercise. And I would push before I started a statin. But many people are, I'm just giving you this disclaimer that I'm probably more conservative in that way than some. Some would start a statin right away.
I'm with you, BG. I'm not thinking of the medication as a substitute or using a medication when compliance is poor with diet and exercise. But after an adequate trial, that means adequate compliance with diet and exercise, there's still elevated lipids,
Absolutely.
elevated cholesterol.
Yeah.
Then we would consider a statin in a 9 or 10-year-old.
Yes, if they fit the criteria.
The criteria. Thank you.
And you make a point that somebody who is not being compliant with diet and exercise is even less likely to be compliant with the medication. So, and then maybe Kathleen can talk about, the reason there's been any controversy is because we know that cholesterol is important for growth hormone and stuff like that. So that's why there is a controversy about it.
Right, and we also don't know the long-term effects in kids. So when kids are metabolically different than adults because of growth and things. So we don't really know what kind of cholesterol flux they need to get to those vital organs, including vitamin D, which is a cholesterol-based hormone. And so we just don't know. We do know in adults that they can tolerate very low levels and do very well. And there are some communities that have a genetically low cholesterol, particularly some communities in Africa where there's very little genetic admixture, and they have longevity. But we just really don't know how we're affecting their ability to stabilize cell surfaces, make the proper hormones for growth, including testosterone, estrogen, cortisol, and vitamin D. So, and I really like what you said about it. It's not an emergency.
Yeah.
I mean, you've got a couple years, and if after 6 months it's unchanged, then shake it up, try something different. Unless you have that rare kid with the genetic cholesterol problem, then I think you've got a lot of time to maneuver. And I would probably phrase it, we like to avoid them at all costs, unless we can't.
It's just, for example, in children with heart transplant, because we know that down the road they might have coronary problems. Questions whether it's atherosclerosis actually, but a lot of the transplant centers put them all on statins. And they get very low cholesterols, and I've tried to look in the literature to find out what is too low, and I couldn't find it. And because in the adult literature, they're pretty much saying nothing's too low, but I can't really find it except for congenital abnormalities.
Yeah, I was trying to think what's the name of the...
And really, that's not helpful because they're not thinking about the same issue. It's,
Right.
so.
And does it also have to do with the need that youth have for cholesterol that is different than adults?
Absolutely,
Such as CNS development.
Yeah, but we don't know the answer, because if you look at like Bugliosa heart study and all these things, it's all based on the fact that they looked at young men in times of war and they saw fatty streaks in their aorta, and that's a precursor of atherosclerosis. And so really, if you look at this literature, it's all based on a couple of large data groups that could have been very different from what we're looking at now. If that was in wars in Vietnam or
Although
World
it could
War
be
II.
worse.
You think it could be worse or
Well,
better?
looking at the diet now compared to the diet of
Yeah.
those young men.
Yeah.
But there is actually there is a significant reversible component.
Exactly.
So if after adulthood or into middle age you still haven't improved, then you can do a statin and you can reverse some of that early plaque deposition.
I have a question. Do you guys ever prescribe omegas?
We definitely that
Yeah.
for triglycerides, we could. We don't have a huge population of cholesterol. Actually, our gastroenterologist, who does hepatology, does most of the really high cholesterol, which makes a little more sense to me. In pediatric cardiology is really a lot of structural heart disease.
Okay.
And actually, I think the pediatricians probably do more general cholesterol stuff than
Okay.
but yeah, omega definitely for hypertriglyceridemia. The little caveat is that some of those kids end up really being pre-diabetic, and so we don't, and they're not that easy to treat with some of the medications for triglycerides.
But even in that situation, if you can get your omegas from your diet, it's going to be a much better deal than taking a supplement.
Yeah.
So, if you're supplementing, if you're changing salmon for cheeseburger, you're going to be way ahead of the game instead of a cheeseburger and an omega-3.
Yeah. I just know in adults, like an inpatient, we had patients on really high dose omega, like prescription only omega.
Yeah. No, we do
I don't
that
know if we do
definitely in
for children,
adults.
too. Yeah.
And that's because we can't get them to.
To make the healthy choices.
And there are
Cost.
again a genetic
Cost of
It
the
is,
supplements.
expensive.
a genetic propensity to hypertriglyceridemia.
Yeah.
And if you add obesity and diabetes into the mix, it's...
So as an adult physician, how swayable do you think the community is getting so that people are more willing to hear your message or not?
I don't think so.
The message about exercise?
Exercise and diet. I mean, I don't think I'm not seeing it.
Really? We have the advantage because they do want to take care of their kids. I mean, everybody loves their kids.
But it's still a struggle.
Yeah.
Yeah, but I think you have that little up.
Yeah.
Well, and I think it's interesting to acknowledge that it's a struggle. I mean, and that's, if Carol were here, she would say from an NMI standpoint, you know, that piece of disclosure that might be helpful, which is, I don't like getting up at 5 o'clock in the morning to go to the pool. I like swimming. I would love to swim at 5 o'clock in the afternoon after, you know, but I have other things I have to do. But that's when I can get there. And I do definitely feel better when I get out, and I have done that, and it's part of my day. But the way to make it fit into my schedule is to do it that way. But it doesn't mean that every time my alarm goes off at 5 o'clock, I don't say, you know,
but
get up
I think the media is killing us, you know? I mean, because like the Olympics being sponsored by Coke.
Yeah.
And, you know, I mean, that's what they see, not what we're saying.
Well, I think we also we're too complacent early on, and let this sneak up on us, if you will, and made all these changes in lifestyle that are now just so hard to reverse. Whereas in other countries like France, I know, they were behind us as far as the obesity rates, but they took swift action as a government and made significant changes. And when, you know, the mayor of New York tries to make a small change, he gets completely blown away by "don't tell me what I get to eat." So I think one of the things is we let it get too far. And because I think our childhood obesity rates are still going up, aren't they? Or did they slow? It's slowing.
The acceleration is slowing.
The acceleration is slowing. Okay, so that's hopeful. But that's kind of one of the things that.
Yeah, when we talk about readiness to change, when I talk to parents of like 2-year-olds and around, when they hear this stuff, they're like, oh, you know, they really do want to hear that. And they don't feel like it's too late yet, but they, you know, the fat, healthy baby. So I also think, and they don't feel guilty yet when you just say, you can say they shouldn't have Coke and they won't. What do you guys think when you counsel people?
I don't know. I think it's hard.
Depends.
Yeah, it depends on the family, but it's really hard to get people to buy in, and they have to have some sort of reward first before they're willing to. That's why they want to just take a diet pill or just not have to do anything. So I think the biggest challenge is getting them over that hump where they identify with some sort of reward. Like, I have more energy throughout my work day, or my kid's so much happier and not crying that she can't fit in her clothes or something. So to get them there is like my biggest struggle, and we just are ever creative. I've written so many exercise plans. Sitting on the couch push-ups is ridiculous to try to get kids to. You know, like the 4th or 5th time they come back and I realize they're not doing anything. I've literally written exercise programs for the couch with pictures. You do tricep things, you do this, you do that.
If there's anyone on the phone, if you have any comments or experiences that you want to share, we're happy to hear them. Obviously, we don't have all the answers. Is there anyone on the phone? Let's see. Okay. Hopefully you're not eating your cheeseburgers.
Well, they may be, knowing that they're going to go take a long run afterwards.
Yes.
Cheeseburgers are not.
Sean and Sylvia, not to put you on the spot, but we know you're out there.
We were trying to figure out how to turn our microphone on.
You're a star.
Anyway, so when I'm talking with kids who watch a lot of TV, I try to get them to identify something they like to do, like dancing. A lot of them like to dance, or maybe you know, with their brother, have a push-up contest, and then try to get them to just imagine doing that during commercials. You know, put the mute button on have your little workout, and you get 20 minutes per hour, and then you get all kinds of benefits from that. But, I don't think it works very well, but I try to get them to do that.
It probably won't work as well this Sunday evening when the ads are so good.
True.
But the
I wouldn't know. I don't watch television.
Well, in your case, you could just watch the commercials and then get up and exercise during the game.
That's right. Yeah. And the game will take, 4 hours for a total of 30 minutes or something like that. 15-minute quarters that last an hour each.
That is a good idea to have exercise on the commercials or like competitions with. I have had some families where I'm like, well, you can race blah blah blah, and they're like, okay.
Now make it a game. Siblings are competitive.
True.
That's a great idea.
Or your parent, you could challenge your parent.
Yeah.
One of the things that we don't watch much TV at our house either, but we have our therapy balls in the living room. So when we do watch television,
you have to sit on those.
You sit on the therapy ball. My daughter, especially my youngest, she's a bouncy person anyway, so that works perfect. So she's sitting on the therapy ball, bouncing during whatever it is that she's watching. And again, it's not very much television watching, but it's funny to see her in there during whatever she's movie or whatever she's got going on. That's another option.
Sometimes I recommend, because we recommend like 2 hours or less of screen time. So I tell parents, if they're going to have an hour of that BTV, it has to be with the treadmill or the Nordic track or something like that. Jump roping you can do and watch a TV show. And they slowly start to do it.
Jump roping's probably hard on the rug, though.
Yeah.
floor.
Depends if you're on the 3rd floor of an apartment building.
Yeah.
Or your jump rope knocks everything off
Right.
Mom's china cabinet.
You have to have a big
Throw all the dishes.
20-foot ceilings.
This is Dan again. I wanted to share about an experience in clinic yesterday, a couple hours before I saw you, Kirsten, which was occurring in the context of treatment for depression and working with a very insightful adolescent, say around 15 years old, who understood how much better she feels when she exercises. And it was interesting that when we talked about resuming a steady exercise plan, what came up was being on the team for that exercise and just getting past that to look at the notion of being with a group of people who like to exercise and doing that together, or exercising when one can fit it in their schedule and it doesn't have to be part of a team competition venue. I think that there's an enjoyment in exercise for people once getting past that heavy traffic or cold water.
It is a very social thing, I think, for humans. And, you get bored when you just go by yourself, sit on the bike, and there's not a book or something. So we always recommend making it social as possible.
Well, and I know just for me, this is Sean again, I had a neighbor who we decided to run together. So at 6 a.m. in December, when it's dark, I know she's outside my front door. I have to get up and go.
There you go.
So finding some way to do it with somebody so that you help each other is good, always helpful.
That is a good thing for safety. I hear. My excuses I've been getting are, it's too cold, they're going to get a cold. Like, put a jacket on, put some earmuffs on.
Yep.
Keep your kid out the door.
Yep.
But safety is an issue now, I think, more than it. Do you hear that?
Well, it's a perception issue, I think. Probably more than it is.
Yeah, I wonder that, because I know there's some neighborhoods in Albuquerque you don't want to be letting your 12-year-old daughter walk around alone in, but I mean, I don't know, so I say, okay, you can do indoor exercises.
Right.
But if you want to, as a family,
drive to another place.
Right.
Like the zoo is fun to walk around with. Of course, there's ice cream.
True.
But I understand the safety issues.
Yeah.
But if you're doing it as a family, you could
drive,
go someplace.
Or just walking along the river. They have nice
walking
nice
together.
paths. Yeah. a good idea.
I get that a lot from my families. That I have continuity clinic at Young Children's in
okay.
International Zone.
Right, yeah, and that's, a lot of those people do not have cars.
Right.
So they have to take the bus somewhere.
So what do you tell them, say?
So, well, there are community centers kind of centrally located throughout the neighborhood that they can get to. So if they can get there, then there are, and I've looked into all of them, and they all have some sort of program, whether it's karate class that runs from November to January, and then they switch to another. So, you give them kind of the ideas. I think the hardest thing that I've run into is the switch to, that short-term, what's in it for me goal, and then also kind of giving the responsibility to them, because they kind of show up and say, well, how are you going to make my daughter's, dinner? Or it's like, well,
I'm not.
Right.
But even there, I mean, you can go to the school. The kids could play on the equipment. You can go to Bullhead Park. That's a short walk away.
Very close, yeah.
And if you walk as a family, then it's probably pretty safe.
Right.
But I think it goes back to the modeling thing we were talking about this morning, is that the child is in the bosom of their family, and if the family doesn't buy into the healthy lifestyle approach, whether it's what's being cooked for dinner, or smoking and alcohol consumption, or exercise, then that child, for the most part, is unable to do that stuff on their own. I mean, they might get it reinforced in a sports team or at school, but again, that's not necessarily going to build a lifetime of behavior unless it's modeled every single day by people either in their home or their community. I think that's one of the things I think that's so frustrating, is that when Jane and I were in endo clinic, we talked about the spare bedroom kids, that we come into clinic and like, man, this would be a good one for the spare bedroom, because you just want to take them to your house and say, oh, just spare bedroom, spare bedroom,
Your own spare bedroom.
my own spare bedroom. If you just take them to our house and they live with us for 8 months, then this problem will go away, because they'll have access to reasonable choices around food. They will have the modeling of activity and chores and responsibilities and expectations for school performance and all of those things, if you can just get them in an environment where they can see that. It's not that the child just doesn't know that those are options or expectations of them, and that given the right environment, they would step up to do that.
That's true. What I think we need to keep in mind is BG was articulate about early in the presentation today, was that in pediatric care we've moved more and more toward working with families to implement these changes so that those changes can be promoted and maintained within the family. We used to have a similar kind of discussion on the flip side at residential treatment centers, where we could offer a better environment for kids with serious psychiatric illness. And they could make gains there only to go back to their family and have further difficulties.
But I think it is really important that it's what their family likes doing, because I agree with you, but there might be some people who don't have the same, the same expectations. So, for example, my husband's a southern boy from Memphis and Italian, and they eat a lot and stuff like that. So just melding, we have different feelings about what you have to go home and relax. And for him to go home and relax, there's not a whole lot of chores and exercise and this stuff he wants. And I actually agree with that. And I think, the idea that when you get home, you're going to do all this work, that might not be what feels good to people. So I think somehow in having it within the context of their family, how do they get them out? Because I got the TV out of the bedroom, but football still. All I hear is, you're lucky I'm not into all sports year round. Not into baseball or basketball.
Just football.
But I do think that, like, trying to sway people, it's not, if they're not into that, it's...
Yeah, and I don't have any illusions that, everybody's going to, do that. And it's not like, I don't make it sound like I do chores as soon as I walk home, because I don't.
Well, my sister sister is one of those who never watches TV, so she's like, well, we don't even have a TV in the house. I'm like, well, we do, and we watch it, and we enjoy it sometimes.
Yeah, no, again, TV's not the enemy either. You know, cheeseburgers aren't the enemy.
It's how you use
it's
it.
how you
because
use it.
you're going to try to not have them do video games, but their life is going to be more electronic than ours, and play gets you ready. So I actually think there's some ways we could use video games that shooting the maybe angry hamburgers.
Develop that game.
Oh, that's cool.
There you go, Kevin. There's your next million.
I know.
It's like the Atari game, fast food.
There is one.
And the healthy food would actually hurt you. The purple pickle
Oh.
Oh
would
no.
hurt you, and you could eat a hamburger and french fries and give you points.
Oh. No, we
What
don't
was that
do
really?
that.
That was like 10 years ago.
We need the
That
opposite.
was only 10 years ago.
No, when I was 10 years old.
Oh, when you were 10.
Same thing.
Okay.
Oh, yeah. 18.
I have a exercise physiology question, if people wouldn't mind moving on to that, or were there more comments about?
Go ahead, DR.
Thank you. I'm referring to BG's earlier eloquent physiology of exercise review. I was reminded by that, and something my daughter was learning for school, about the notion of BMR, basal metabolic rate. I remember earlier literature, dating myself again, earlier exercise physiology literature seemed to talk, as I recall, about basal metabolic rate and how regular aerobic exercise increases fitness with regard to increasing one's basic metabolic rate. Is that still thought of as a way of reducing one's BMI because of a rise in BMR?
So I haven't used that BMR, but I know what you're talking about. But clearly they talk about as you exercise, it's not just that hour that you're
Right.
benefiting.
Right.
It sets you up for how you're using your energy stores. For
That's right. More of the notion of it tends to stoke the furnace, and the furnace burns even hotter. And
But I think maybe Kathleen can talk about this, the idea that what amazes me all the time, I mean, if I were to carry a 100-pound backpack around all day, why wouldn't I just lose weight, right? And so the other end of decreasing your BMR when you're obese or what, do you have any comments about that?
So,
Use of energy?
yeah, I'm trying to remember. So the basal metabolic rate is a rate we all have just sitting here doing nothing, and it's the cost of breathing, of our heart beating, making different things in our body, sweating, etc. And then anything above that, you get increased credit for. So, but the more rigorous the activity, the longer, even when you stop that, as Beth said, that you're going to have your basal metabolic rate is going to be higher for a set period of time. So you're going to use things more efficiently. On the flip side, when you're heavy, actually you tend to have a higher basal metabolic rate because you're carrying more around. And whether that contributes to eating patterns or increased eating, it's probably related. And then on the flip side of that, when people start to diet, even when they're overweight, their body senses that there's not enough calories coming in, so basal metabolic rate goes down. And that contributes to the plateau that dieters experience. So they get the first 10 pounds off, and then they just kind of stay steady. I actually talk about that a lot now with patients, because getting that first 10 pounds off is pretty metabolically good. So if you weighed 200 pounds and you lost 10 pounds, you've lost 5%. And that's enough to actually make some pretty good dynamic changes in the body to counteract the previous damage. So I actually try to talk about that so that they don't say, well, I'm just going to give up. like you got there. Let's just try something different now. So there are changes that happen based on your weight, and some of them are counterintuitive.
Well, and the way we think about it in nutrition, that's one of those things that we use for hospitalized patients, especially when you don't have activity, or you're looking at things that change energy needs, which would be infection,
Burns,
sepsis, burns, fever, trauma. All of these things that increase your body's need for nutrients and also increase the need for energy, just because you're doing lots of things that you would not normally be doing. So somebody's energy needs can be higher in the hospital than they would be free living because of all the healing that's going on or the infection that's being fought or whatever. But the other thing has to do with lean body mass. So people who tend to have more lean body mass will have a higher basal metabolic rate. So one of the arguments you can make for people who are working on that exercise, sort of the magic bullet, is that you get 7 to 12 hours, sometimes 24 hours of metabolic activity from exercise, which is why it's so hard to take care of children who have type 1 diabetes, who are trying to exercise. Every individual's response to that incident of exercise is different. So you might not see it in the first 2 hours, but the kid might have an effect 7 to 12 hours later that you weren't thinking about. And it's only after following them for a period of time that you realize that's when we need to make the adjustment, not here, because we're getting a delayed effect with their glucose. You're delayed. So it's kind of a funny thing. But if you just look at lean body mass, muscle tends to have a higher metabolic activity. So that's one of the ways that, as you're talking with families and patients about changing their weight, it may not give them the size jeans that they want, but the fact that they're actually changing that body compartment a little bit and they have more muscle.
And that works so well with boys because they all want to work. I mean, they're fine with that, with building muscle mass. Whereas before, in my day, we would talk about just aerobic, and it was things that girls did, like dance and stuff. But that muscle building.
And the unfortunate thing about your, idea of carrying the 100-pound backpack, if you carried a 100-pound backpack on your frame the way you're built right now and didn't consume any more, you would lose weight.
But you think that I'd be consuming more.
But that's different than somebody who already is in this metabolic pattern of not being able to do things, so they're not fit anymore, so they can't even really manage doing that, to that level of activity, and in fact feel bad. Their perceived exertion is actually higher given the fact that they can't tolerate carrying around that 100-pound backpack wherever it's distributed.
Well, that's why I think, Kirsten, sometimes it doesn't feel good for quite some time until you get fit. So you can say that you'll feel better with exercise, but I don't know that it feels better.
Right on.
But I think just acknowledging that is helpful.
And not to jump into it too quickly, which I think you pointed out, that, and the thing that we talked about this morning was also that idea of that 10% increase.
Yeah.
Wherever you are, don't go up more than 10% in a week's period of time because it's too fast. So not only would it make you not feel good, but then the concern is in children is injury. If they go from, they have the soccer season off in the winter and they don't do anything for 3 months, and then you start with practice this week and all of a sudden you have an hour and a half practice 4 times a week like you did before, you can't assume that those kids are in the same shape that they were at the end of the season in November or December.
But we talk about that a lot because if you have a time off, like especially the orthopedic injuries, the kids will say, well, I was doing well, but I sprained my ankle. And so going back to it, I think they have to be important that they don't go right back to what they were doing, like you said.
Build up again.
We have a lot of kids that, especially our really overweight kids, they kind of make up their mind they want to do something, try out for a sport, get hurt, can't keep up, totally give up. And there's no integration period for them. It's either you make the team or you don't. So, and it's hard to, and then they get depression. And
they don't feel good because they hurt themselves.
Yeah.
Well, in the teams, there's not enough people who can be on the team.
Right. Yeah.
And so that's why I don't think you can rely on the schools no matter what. Even the healthy kids, like the basketball team, there's only 5 guys who start or whatever.
The rest of them sit there.
And if you have a big school, that's such a small percentage of the population.
And we had a a kid not too long ago who exactly that dynamic. He had wanted to play basketball, and he was too far down the line. They had X number of uniforms. That's how many kids could play. Was it?
Yeah.
Yeah, it's not very, I mean, even football, 11 guys on the, it's just not that big part of the student population. So I don't think the sports are really going to do it. And competitive, Dan can say that. I mean, some people just don't want to compete because it's going to make them feel worse than better. So.
And some people have difficulty doing it if it doesn't involve competition.
Yeah, that's true. Both.
And so if you want the competition but you can't, you happen to go to a place where you're not going to get on the team because there are X number of spots, then
Yeah, and they're really not as attracted to it unless it's a competitive opportunity.
Yeah, we've had a few kids like that.
And so they get de-incentivized or disincentive for doing something.
There's, I think, another, you sort of brought it up that they get on the team and then they get hurt because I think the coaches don't give them time to slowly build up. You know, they just put, they don't want to not do it because then they're perceived to be lazy, and of course fat makes you lazy, right? And so they push themselves too hard and they get hurt, and then they get depressed and give up.
So this is for my cardiac kids, so it might not work just because of obesity, depending on your coach. But we have some kids that we do worry if they push themselves too hard. And so what we sometimes do is we ask the parents to get to know the coach and develop a signal that the kid can ask to be taken out without anybody else recognizing the signal other than he and the coach or she and the coach. Because I think a lot of it is peer pressure, and you know, in heart disease, we're worried they're going to push themselves beyond what they should. But maybe we should be thinking about this for some of the kids who are trying to improve the health in other ways, because it is embarrassing if you're being pointed out. Oh, you can't quite run as much. But if the coach should be a child advocate and not just wanting to win.
Should be.
But that's often not the case.
That's a fairly large assumption.
That's a good idea, just to do like at public pools or with the parent and child, you know, to let your parent know. Because they'll get embarrassed, you know, just playing at a family reunion or something. Yeah. But if it's the parent saying come, then they're like, okay, you know, sorry, my mom's calling me, you know, and they have that excuse. That's a good idea, though.
That's a good idea.
Okay, well, think we solved that problem. Our next session will be the 15th.
Yeah, so we're going to have a sequel to 2 weeks ago, getting back to depression, about treatment approaches to depression in overweight youth. Maybe exercise could be added as one of them.
I think it could. For those of you who enjoy partaking in Valentine's Day, you can now get fruit bouquets instead of flower bouquets.
Sweet.
So I highly recommend that instead of the box of chocolates as well. Or go on a long walk, a long, quiet walk on the beach. Harmony.com.
Yeah, maybe Forrest Gump could
with the bouquet of
promote
flowers.
that product you're talking about, Dr. Color.
Thank you, everyone. Thank you, Dr. Goens.
Thanks.
Thank you, Kevin.
Thank you.
I think I'll